Well, good afternoon, everyone. My name is Ryan Johnson, and I'm a corporate healthcare attorney and shareholder at Frederickson and Byron, and a member of the firm's Health Law and Life Sciences groups. I also teach health law in the Healthcare MBA program here at the University of St. Thomas. It's been my privilege to partner with St. Thomas and Clifton Larson Allen to pull these Future of Healthcare webinars together. It's my honor to welcome all of you to today's webinar. Thank you for joining us. Now, before we get into today's session, I'd like to cover a few logistical items. First, this is our third in a series of 6 monthly webinars we'll be delivering to replace our traditional day-long annual Future of Healthcare conference. Our next webinar will be on Friday, February 12th, when we'll be welcoming Dr. Nathan Chumillo, who is the Medicaid Medical Director for the state of Minnesota and a Health Partners physician. He will discuss what their organization is doing to advance solutions in the areas of health equity. Now, in a few business days, you'll receive an email with links to the recording of today's session, the presentation decks, and the registration page for our next webinar. A link to that registration page will also be provided in the chat feature of this Zoom session. All right, for today's agenda, each of our presenters is going to give a brief presentation. Our first presenter is Dr. Anthony Iton. Dr. Iton earned his BS in neurophysiology from McGill University, his JD from the University of California, and medical degree from Johns Hopkins University School of Medicine. He has served as the director of Alameda County Public Health Department, director of Health and Human Services, and school medical advisor for the city of Stanford, and is a physician for Stanford Hospital's HIV clinic, among other roles. Our second presenter is Jennifer DeCubellis, with an MA from the Illinois School of Professional Psychology and a BA from the University of Wisconsin-Madison. Jennifer has served as the Assistant Commissioner for the Minnesota Department of Human Services and as the Assistant County Administrator and Area Director for Hennepin County. She has also worked as an Innovation Advisor for the Center for Medicare and Medicaid Innovation and has led the Mental Health Authority Services in Texas. All right, now following their presentations, we're going to spend time with you in a Q&A session. For the Q&A portion of today's webinar, I'll be joined by my friend Janet Tolander, who's a member of our conference planning committee. Janet is a principal at Clifton Larson Allen and leads CLA's healthcare advisory, accounting, and tax services in California. And of course, we're going to leave plenty of time, hopefully, for questions from you. Please use the chat feature to ask questions at any time during the session. Just make sure to address them to all panelists. And we're going to hold questions until the end of the presentations. Now, our goal is to end a bit before 1 o'clock so you have time to transition to your next meeting. And without further ado, it is my pleasure to welcome Dr. Anthony Iton.
Good afternoon. It's morning here for us out in California. And it's a pleasure to be back virtually in Minnesota, which is one of my favorite places. I'm going to take you just through a quick whirlwind description of some data in some public health science that makes an argument about what the root causes of health inequity are. And this is a much shortened version of a much longer presentation. So if there's anything that I missed that seems confusing to you, we hopefully can get to it in the Q&A. And so I believe I have to share my screen now. So let me do that. And I hope somebody will tell me if I've got the right screen up. Is that the right or the wrong one? That's the right one? Okay, good. All right, so, I titled this talk, Health is Political, intentionally because I'm trying to provoke you a little bit. And I learned in medical school a long time ago that you got to state your conclusions up front. So let's see if I can get this to advance. Okay, so one of the things they teach you in medical school is to think about health as behavioral. The folks that drink, that smoke, that drive without a seatbelt, that have sex without condoms, they're behaving in a risky way. And those behaviors are something that the healthcare system tries to change. And so there's a paradigm about individual behavior change, which is very powerful and dominant on the health realm. There's another paradigm, which is that health is transactional. And by transactional, I mean that it's the product of services. And so it's the frequency or quality of medical services that dictates good health or poor health. And a third paradigm is that health is genetic. and that in essence, we're dealing with a lottery. Some people get good genes, some people get bad genes, and it's sort of like, oh shucks, the folks with bad genes, we just have to provide them more medical care. You'll note that all three of these paradigms are individual frames, meaning that they deal with individuals experiencing their interactions with our society. And so we hold them accountable for good behavior, accessing the right kind of services, and hopefully having the right genes. And I want to argue to you that all of these frames are just a little bit right, but so little that they're essentially wrong. And the frame that we should really be thinking about is health as a political frame, small p political. And one definition of politics is that politics is the struggle over the allocation of scarce or limited precious social goods. And this definition I like in part, I dislike in another part. I like it because it makes it clear that politics is a struggle. And the events of the last couple of weeks really clearly indicate that. But at the end of this struggle is an allocation of goods. And those goods may be things like a grocery store in your neighborhood that serves a full range of fresh produce, or a park in your neighborhood where your children can play safely. The reason I don't like this definition as much is because I don't like the word scarce. I think that there's a narrative in this country that tries to exaggerate scarcity, and it's a false narrative. Nevertheless, I'm going to argue to you, showing you some data very quickly, that health is in fact best explained by a political paradigm rather than any of the other paradigms I showed you before. And if health is political, it means that power matters. And I'm going to talk about that a little bit as well. Okay, I'm also going to say that health is not healthcare. I think many of you know that. Where you live matters, and it matters a lot, and I'm going to try to prove that to you. Okay, so place matters. I went to medical school at Johns Hopkins Medical School, which is situated in East Baltimore, Maryland, which is probably one of, and historically has been over the past 50 or so years, one of the most notorious inner cities or slums, quite frankly, in the United States. And I left that medical school with this question on my mind, which was, when it comes to your health in the United States, does your zip code matter more than your genetic code? And I started trying to prove that to myself, in essence. I became the health director and health officer of Alameda County, California. For those of you who don't know what that looks like, here's a Google map. That's San Francisco, and you see that blue area is the San Francisco Bay. And then just east of San Francisco is Alameda County, which is shaped like a big boot. And I'll show you a couple maps in a second that will show you how that plays out. I became the health officer there. And when you're the health officer, you're the registrar of all births and deaths. And there are about 20,000 births in Alameda County every year and about 10,000 deaths. And each of those deaths has a death certificate. And each of those death certificates required my signature on it before the body could be buried or cremated or otherwise dispensed with. And so the death certificates provided a very solid database for analyzing patterns of death in Alameda, California. On every death certificate, you can tell what somebody died of, what their age was when they died, their race, ethnicity, and where they lived. And those 4 pieces of data can paint a very compelling picture about patterns of death in a place. So we took our death certificates and we put a database together of about 500,000 death certificates. And we took Alameda County, which is shaped like a boot, and we looked at every census tract, or which is roughly the equivalent of a neighborhood, and calculated on average how long somebody could expect to live in that neighborhood. And what we showed was in those green neighborhoods, people could routinely expect to live above 80 years. In the red neighborhoods, people could only expect to live to about 74 years. And then in the yellow neighborhoods, it was between 74 and 80 years. And what was interesting about this map was that the low life expectancy neighborhoods clustered. They clustered in places like East Oakland, parts of Berkeley, and parts of our unincorporated parts in the county. And this was surprising to a lot of people, so surprising that it ended up on the front page of the San Francisco Chronicle, and it stimulated a lot of policy discussion. One of the questions people would ask is, why is Alameda County so unique? And in order to answer that question, which was, to my mind, really not the right question, because this is not a unique phenomenon in Alameda County, we decided we would go around the country, work with health departments to do this analysis in a variety of different places. So we took our Alameda County map. I had to go back to Baltimore, Maryland, where I went to medical school. And in Baltimore, you have neighborhoods with life expectancies on the order of 58 years, as well as others in the northern part of Baltimore with life expectancies approaching 90 years. We went to Cleveland and Cuyahoga County and found a neighborhood called Huff with a life expectancy of 61 years in East Cleveland, and 1.8 miles down the road in Lyndhurst, you have a life expectancy of 88.5 years. They also went to Denver and to New York City and to Seattle, King County, and to Los Angeles and Minneapolis, St. Paul, where there a number of different researchers have done this analysis and found striking life expectancy differences across the Minneapolis-St. Paul region. We went to Boston, we went to Philadelphia, to Texas and San Antonio, to Chicago. Everywhere we looked, we found life expectancy differences on the order of 12, 15, 20, 25, in some cases 30 years of life expectancy difference across the same city. And the question for us was, how do you explain these patterns? And when you go back to the first slide I showed you, you cannot explain them by behavioral differences. You can't explain them by differences in access to healthcare, and you can't explain them by genetics. The best explanation for these differences is that they correlate very closely with political power. The other thing that we recognized is that in these neighborhoods where you have essentially denuded landscapes, you have a lack of significant access to healthy food, to recreation, decent transportation, jobs, in some cases even potable water. People experience an enormous amount of stress in these neighborhoods because they're searching on a day-to-day basis for basic amenities to allow them to live a healthy life, and it's difficult to find those amenities. We know through science that 80% of what shapes your life expectancy happens outside of the healthcare system. In fact, 80% is probably too low. It's approaching 90% in more recent research. And we think the reason for this is essentially chronic stress. There are a number of stressors in our society and in our environment. And this notion of allostatic load is when the stressors sort of overcome your ability to cope and they start to change your physiology. And those stressors may manifest themselves in any number of different ways. It may be inadequate transportation with long commutes, poor quality housing that's super expensive, being socially isolated and feeling despair, experiencing racism, having so-called high demand, low control jobs. Many doctors often complain of that. Lack of access to stores or other basic amenities, or experiencing crime. These stressors change our physiology. Our body perceives the stressor through our brain, primarily through the hypothalamus, which sends a message to our pituitary gland, which sends a message to our adrenal glands, which release a cascade of hormones, amongst which is cortisol. Cortisol in the acute state, which is in the blue, is good for you. It's good for you in stress because it helps you respond to an acute stressor. It increases your cardiac output. It stimulates glucose for your muscles in case you need to flee or to fight. It enhances your immune functions. It turns down inflammation. I mean, we think of steroids as anti-inflammatory. That's what they do in the acute period. And it stimulates the growth of neurons in the hippocampus and prefrontal cortex, which are part of your brain that are necessary for what's called executive function, which I can talk about in a minute. But executive function, in essence, is the ability to do triage. It's the ability to sort of make a good decision when your options are very different, comparing apples to oranges to grapes and deciding what the best fruit is for that moment. However, when you're constantly bathed in cortisol, not in acute like in the blue, but now constantly, day in, day out, 24/7, enshrined in a fog of chronic stress, cortisol does a very different thing to your physiology. It stimulates hypertension and cardiovascular disease independent of your diet, i.e. independent of your behaviors. It's a double whammy because it also encourages the body to crave high fat, high salt, and high sugar foods. So you get it both directly and indirectly on the cardiovascular system. It causes glucose intolerance and insulin resistance, which are precursors for type 2 diabetes. It turns up inflammation and turns down your immune system, so you're more prone to infection. And it causes atrophy and cell death in that same part of the brain that I told you was responsible for executive function. So people are actually thinking differently in that fog of chronic stress. They can think much more about short-term needs. They have a much more difficult time thinking long-term. So I've begun talking about people living in low-income communities that are constantly enshrouded in a fog of chronic stress as being physiologically different from people living in other communities where they have access to resources. They're physiologically different, not because they were born that way, but because we made them that way through policy, or in most cases, the absence of policy in the face of abject need. All right, let me conclude by summing this up for you with a framework for thinking about this. And it starts with the medical model framework, which is basically, if you read this from right to left like Chinese, you start with death. When you see premature death, like I showed you on those maps, you think upstream and you think, okay, well, these people must be experiencing a higher burden of disease and injury. And in fact, that is the case. And then you think, well, why are these people in these communities experiencing a higher burden of disease and injury? Well, in fact, they're experiencing much greater risk. And that risk takes two forms, both in risk factors and risk behaviors. That's absolutely true. That, however, is where the medical model stops. It just assumes that it starts with behaviors that produces morbidity, which creates a higher risk of mortality. And the variables that the medical model plays with are tinkering with genetics, trying to change what people do, pretty much through using brochures and pamphlets to try to change behaviors, and then facilitating access to 15-minute encounters in a cubicle with a healthcare practitioner, with the eye towards this being an opportunity for that healthcare practitioner to disgorge their wisdom into the waiting beaks of the supplicant patient who is there to just learn how to live. I'm being cynical, I admit it, but I'm trying to simplify the concept here so that we understand. So the medical model, which is a $3.8 trillion enterprise, is necessary but not sufficient. And what we've argued is that there's a whole set of upstream precursors that we can intervene in to reduce the burden downstream on the healthcare system. And we argue, again, reading from right to left like Hebrew, that this starts with social inequities that are politically created. They're politically created by, if you move one box over, by institutions like government, but also private corporations that create policies that steer resources away from certain populations and towards other populations. And the question is why? Why do these policies and institutions behave in this way? It comes down to that first box, which is fundamentally discrimination, and in many cases, racial discrimination. And the history of this country is pretty clear about not just slavery and genocide, but a history of steering people away from resources when those people are perceived as being less valuable and those people have less political power. Okay, so health disparities live downstream. Health inequities live upstream. You can take the word health out and just talk about inequities producing disparities. Or if you're simple-minded like me, you talk about conditions that produce consequences. And these consequences are not just for people of color. We've seen profound deaths of despair in this country amongst white, typically middle American, rural Americans that are experiencing a dramatic decline in their social and economic opportunity. And they're experiencing that through despair. And that despair produces self-inflicted harm, including high rates of suicide, high rates of alcohol-related mortality, and then drug overdoses. And we've seen over 500,000 excess deaths in these so-called deaths of despair amongst white Americans, which exceeds the number of deaths from the entire US HIV/AIDS epidemic. So it's not just people of color that are experiencing these problems. And it's not just in healthcare. You see these consequences in education. you see them in employment, you see them in a whole host of different domains. And our argument is that we have to focus on those upstream factors and be much more deliberate about intervening in a way that heads off the downstream cascade in the healthcare system. My organization has simplified the upstream practice to think about three domains: narrative, policy, and place. And what's critical is building power amongst people who are experiencing these inequities in real time, because they hold the solutions that are most workable to head off the kinds of inequities and the health consequences that result from that. Okay, finally, healthcare costs live downstream. Health is an expenditure, healthcare is, but health itself is an investment. And if we can invest upstream, we can reduce costs downstream. That's the name of this game, is to move those downstream costs into investments upstream. That creates a virtuous cycle rather than the vicious cycle we're experiencing now, where we don't invest upstream and we're experiencing higher and higher downstream costs. Okay, that's my short march through some of this data, and I'll turn it back to my colleagues.
All right, well, Dr. Iton, thank you very much for that thought-provoking presentation. We're starting to receive questions in the chat box, but please keep them coming. Before we get to your questions, we're going to hear from Jennifer DeCubellis. Jennifer, please take it away.
And I think that the next version of this, I think I could talk to Dr. Iton all day long based on what you just shared, and not having heard him speak before. I'm hoping that this next version talks about some ways that we can move that line in healthcare and across collaboratives. So I'm excited about the dialogue, and I'll try to watch my time to make sure I leave plenty of time for that. So thank you for letting me join this discussion today. I am Jennifer DeCubellis, the CEO for Hennepin Healthcare, and I have a background in special education, and then moved into clinical psychology, and then moved really into design work for systems. And my passion is to stop having systems, putting people into systems, but truly getting systems to work for the people they serve, which is why 11 months ago, I accepted the position here at Hennepin Healthcare. 2 weeks later, COVID-19 hit, and that's a whole nother discussion right there. But with my background in human services, in healthcare, in social services, in public health, and in policy development, it clearly painted a picture of what is a huge opportunity, I believe, in healthcare to move the line. Sorry, I'm going to get a logistics problem here. There we go. So a little bit quickly about who we are at Hennepin Healthcare. We are an integrated health system. We are a top trauma facility. We do trauma for adults and pediatrics. We're in the top 1% for the lowest mortality rates in the nation. And so we do trauma really well. What we have learned is responding to trauma alone isn't enough, and we need to build that investment in health, in wellness, in ambulatory, in clinical care out in community for the people we serve. We've got 26 primary care and specialty care clinics. We've got an EMS system that provides paramedics across 14 different cities. We're a teaching hospital. So we provide clinical training for 70 other health professions, and have a state-of-the-art simulation center, as well as over 50% of the workforce that comes through healthcare in Minnesota are trained through the Hennepin Healthcare system. So we know we have a tremendous footprint and a tremendous impact if we change healthcare for the better. We also have a significant research arm that supports more than 200 investigators, including physicians, PhDs, and administrators. And we also know through that research and innovation arm, we can track the data, track the impact, and ideally help paint a picture forward for what healthcare should look like. Healthcare by the numbers, this just shows the size and scale of our organization. And with 7,000 employees, it's a heavy lift, and all the trainees that we have coming through our organization to say, how do we work on teaching the workforce of the future, but teaching them with a lens of how healthcare should really work going forward. And what we see across healthcare is we've got two main challenges that we've been trying to solve for. One is funding and the other is outcomes. And I would cover these quickly, that funding. And Dr. Iton mentioned it a little bit earlier. We are one of the top nations in how much we spend in healthcare. If you look at government budgets, it's the big chunk of budgetary responsibility is coming into healthcare. We invest much lower than other nations in social services. And I'm a firm believer that none of that matters. I believe we have enough money in the system. How we're leveraging that money, how we're working together across sectors is what needs to change. And I'm hoping today to give you a couple of examples of that. So funding is unsustainable. Something needs to change in how we're leveraging those dollars. The other item on here is outcomes. Minnesota is known as a top healthcare state. When indicators come out for health, we are usually in the top 1, 2, 3, sometimes 4, but we don't drop that low for healthcare outcomes for Minnesota. So people often turn to our health systems to say, what are you doing and what's working? What that tells me is we have enough money, we have excellent services, but as soon as you sort Minnesota's data by race, we're 46th, 47th, or 48th in the United States. That tells us that there is a whole population. It's not the system that's so broken, but there's a whole population, as Dr. Iton mentioned, that isn't getting access, isn't getting the right access, or healthcare is not standing up in the right way. So that's our challenge as healthcare, to figure out how do we lean into that, acknowledge it, and change how healthcare shows up in our community. One of the ways we did this early on through Hennepin Health and Hennepin Healthcare is we looked into what are some of the system drivers. We did a top 100 review, and we said for the top 100 utilizers of healthcare in our system that we're predominantly seeing in emergency rooms, let's take off because there's been a trauma. Let's take off if there's HIV, AIDS, or oncology, things that we expect to be expensive. But everybody else, it shows you where there's gaps and where the system isn't working well. But we started with data to find out what was the problem and what was the driver. And what you'll see here is what we found. So Hennepin Healthcare, because we are a safety net essential hospital, 70% of the individuals who walk through our walls are on public programs. 60% are people of color, Black, Indigenous, or other. And what we found is for our high utilizers of services and care, this is what we saw, is that alarmingly 93% of our patients interact with more than one public system. Greater than 30% are involved in healthcare and human services, and yet these systems aren't working together. They're separate funding streams, they're separate programs, and it goes back to my intro remarks about putting people into programs versus wrapping the right supports around individuals we serve. So what we did is we looked at what were some of the underlying diagnoses, what were some of the underlying social influencers that we saw. And what we looked is that there was a crisis cycle that individuals were stuck in. They were hitting the system over and over again, but we weren't taking a system response. We were putting Band-Aids on. We were addressing the one reason that they showed up at our emergency department versus digging deeper and figuring that out. And I would give you an example of if we see somebody who's coming in and hypertension is driving a concern. If we just treat that hypertension and don't understand, as Dr. Iton mentioned, all the other social factors that are underlying that, I can guarantee you we're going to see them right back in. And so as healthcare providers, we often label people as non-compliant with our health plans versus seeing that our treatment plan isn't addressing what matters most to individuals. And I'll tell you a story about an audacious, we had a community health worker that got ahead of a physician one day. Typically in our model, community health workers came behind physicians who were seeing people in clinic, and then they said, what are some of the things we need to connect you to, and what are some of the social challenges that you're having? And I had a physician get in front of me and say, you know what, I had a audacious worker, I was running behind, and she jumped in that door before me. Been treating this individual for 10, 15 years and constantly could not get her to take her medications. And he goes, I suddenly walked into a room and she looked at me and she said, Doc, I've got some medical problems. Let's talk. And what do I need to take and how do I need to take it? And he said he was stunned. He didn't know what the difference was of what was sitting in front of him. And what had happened is a community health worker had come in, had found out there were all sorts of social stressors going on, had put a plan together, had gotten interventions in front of him, and taken that immediate what matters to me and resolved it and got a plan. So now the individual sitting in front of the physician could actually focus on what the physician was there to provide. And it tells us, again, how it's not a transactional relationship we need to have with individuals, but how do we truly show up differently? These social influencers we've mapped out here, and this is as we looked into our data, what we really saw is that the drivers of health, as Dr. Iton mentioned, that 80% of things that happen and impact people, if we don't address them, we just create the spin and we are part of the problem. And what we saw is it's not just about healthcare. It is about overall health. It is about, do people have employment? Do they have housing? Do they have food instability? Do they have income? Do they have education barriers that are holding them in poverty? And that's what matters to them, and we're not addressing it. And what it taught us is how to look at those and think differently about how we intervene. So what do we do about it? We started looking at building business cases. And what we found is clinicians are incredible with clinical work. Social workers know social work. Public health knows how to do health education and outreach to communities around disease. The list goes on. But what we're not always good at is talking across sectors, partnering across sectors, lending our funding, building a business case that brings us all to the table to look at those equal wins, and moving true system transformation forward. I often say we're nibbling around the edges. We put in some good projects, we feel good about it, we get some great media. If at the end of the day, it didn't change the outcome for the individual, media shouldn't be paying attention, because our community, we gave them a Band-Aid. We didn't solve the root cause of what's going on. One of the cases we saw was early on in our top 100 is we saw care that individuals were coming in, they were high utilizers of the emergency department. And I'm going to speak a little bit about some of those case studies we went through. Actually, I'm going to back up one slide, my apologies. The business case, what we found is that people didn't know how to do these, and so we needed to help teach. And so this is a common thing that we are working on through education. It is to say, what is the problem at the end of the day from the patient's perspective? Who are your key stakeholders that you need at the table that have an invested interest in getting to a solution? Identifying your pressure points. What does your data tell you? What are some possible solutions? And then how do you fund those solutions? And I'm going to talk through in a minute about how we worked to move the money, which is exactly what Dr. Iton talked about, is how do you get the money from the healthcare system focused on the root cause and those true resolutions that individuals need. And what we found is it was really important to track outcomes and having balancing metrics. So we weren't just blocking people from getting to the emergency department. We were truly providing life-changing services and supports that were helping them not need the emergency department. And then how do we use that ROI, that return on investment, to reinvest in the next innovation, the next opportunity that changes the line for community? And when we get things that work, how do we bring them to scale? How do we make sure that they become the system, not a project that has separate funding and with tough budget times can go away, but truly becomes the system? And I'll talk about how we've done that through moving not only the money, but the policy and bringing items to scale. This is a sampling of some of the efforts that we have done. And what I have in here is the numbers of the ROIs that we saw, whether it was inpatient ROIs or outpatient. And I'll highlight a couple of these very quickly. The emergency room diversion was one of the first things we did. Is we looked at top utilizers and we saw dental pain was what was bringing people into the emergency department. And this is a simple healthcare example. But when you look at the healthcare system, we tracked the problem to say it's not about the dental pain. Think about the costs that we waste when we see them in the emergency department. We give pain medication. We tell them to go to the dentist. They don't have transportation and means to get to the dentist, or there isn't a dentist accessible. We often worsen an underlying addiction. And then we find them back in the emergency department 3-4 days later, and we're surprised they're back. We spent a lot of money. We set them up to fail. And at the end of the day, we didn't get at the root cause of the tooth pain. What we did is we put mobile dental clinic chairs into our emergency department as a first test of change. And what we found is about 50% of the people didn't need that service. They exited the building and chose not to get the dental care taken care of. The 50% who got it taken care of, we resolved the problem, we lowered their costs, and we were able to get them the resolution. Those that exited our building, we needed to dig further and understand what were they seeking, and was it addiction? Was it pain medication? And then how do we change the implementation and the interactions that we have with those individuals to get them to better results? I'll quickly highlight a housing initiative. We took 200 people that were unhoused, and we were seeing them cycling through our emergency department, and they couldn't get wounds to heal. So they were in our wound care or our burn center. And we know that as soon as we release them back to the streets, they're going to come right back in with a new infection, and we're going to keep that cycle going. What we found in this is by housing those 200 individuals, getting them connected to employment programs, education programs, social services, we reduced our costs by 55%. We could have bought a 5-bedroom home for the individuals that we helped get into apartments. We didn't stop there though. What we did is we took that policy and we started talking at the federal government with CMS about why housing. You can't use Medicaid dollars for housing, and where that policy was getting in our way. Years later, we have the ability to leverage Medicaid dollars for housing supports and putting those support systems into those housing venues. I would use another quick example on withdrawal management. We saw a lot of chronic inebriates in our emergency department. And what we identified was we needed more. Our detox beds were full by 4 o'clock every single day. We went and talked to folks about bringing on new beds. In Minnesota, it's an unfunded mandate at the county level. And so if they build more beds, we started to follow the money based on that business case. And what we found is if they build more beds at the county, it's a county cost. It's the right thing to do. We knew getting people into recovery and getting them connected was the right thing to do. If we built more beds, who saved money? The health plans saved money. So our first stop of building that business plan was to say, we truly believe it's greater than 60% better utilization to not throw them through an emergency department where we monitored them, watched them until they were sober enough, tried to give them a referral for connection to services, and they walked out our door and they were back in a couple days later, if not the same day. So to stop that crisis spin, we followed the money. And what we did is went and talked to health plans and said, would you invest in something that was 60% lower cost? Here's the metrics, here's the data, here's how we can connect them to community-based care, long-term recovery, peer supports, get them into housing, get them into those work programs. And we got health plans to agree to walk alongside us because we demonstrated if they paid for something they weren't legislated to have to pay for, they'd get a better outcome for people and they'd save money. But we didn't stop there. We then went to the state and started talking to the state and sharing our data and sharing the life-changing moments that people were now working. They were stably housed. They were well on their way to recovery, and shared the data to say, if we invest smarter as a state and we make sure we create a path to build these programs intentionally, took 5 years, but 5 years later, withdrawal management is a state resource here in Minnesota. And so what I highlight those is to say the money is there, but we can't stop with saying it's somebody else's problem to solve. In that withdrawal management opportunity, we could have said it's the county's problem. The health plans could have said, no, they're not going to pay for it. It was cross-sector systems coming together to think differently, to get to better outcomes for individuals that at the end of the day made the difference. Here is a smattering of, if you create an ecosystem of who are your partners and who are your key movers of systems work, all the different examples of where we've been able to get better outcomes, lower costs for individuals, change policy, change programming to really move the line. And I encourage all of us that this is where we need to spend our time. Behind this, and I'll wrap up, is just a lot of examples, and you'll get these slide decks of designing primary care clinics that look different. We went and talked to community and learned that how we were providing access to care was problematic. But you'll see in the graphic, we built what they said they needed. We listened to what mattered to individuals. We partnered across areas to make care easy, to bring welfare, healthcare, women and children WIC programs, public health all together to work differently. And what you'll see is our total cost of care per 1,000 went down. It puts money back in the system. It's lower cost, and we started seeing people connecting longer term to primary care who hadn't historically been connected. Integrated access team is another one I'd quickly highlight. This is an access team that went into the jails. Again, policy gets in the way. We see a lot of people booked in our community, in our county jails that have mental health and addiction that is driving the offense that got them in. And as you heard Dr. Iton talk about, there's all sorts of social stressors that even get them to that point. What we did is we said what they really need is connections to care, not booking. However, there's policies that get in the way and that you can't bill for those services. So all the provider systems said we're not in. What we did is we again said who benefits when we get them to not be in jail. Let's go to that funding stream. Let's build a plan for a different model. Let's invest in it and put the right caregivers in there. And let's see if we can get people out of the criminal justice system. And you'll see here, we had a drop in 26% fewer ED visits. We had 48% of them not being rebooked into jail. And this was over a 1-year time span for individuals who were frequently in and out. We now have medication-assisted therapies happening in the jail. We have assertive community treatment, which are intensive case management programs working in the jail. And what they're doing is pre-booking. They're grabbing people before they even get booked and saying, Judge, we're going to divert. We want them in healthcare. We want them in social services and supports. We want them in those employment programs longer term. And this is a final example of employment programs. If we can get to those root causes and not stop because we feel it's not our role and responsibility, this example is where we brought employment services and supports into individuals who had 10 or more psychiatric or addiction visits within a 1-year time span. And what the graphic down below shows you is what the cost for them across our systems, our public systems, was before the intervention. And when we got them into employment programs and ideally into career pathways, not just jobs, you'll see after hiring that those crisis points stopped. The costs across all systems dropped dramatically. And what we just did is we invested in a different future, not just for that individual, but for generations beyond that individual. We stopped the crisis cycle by acting differently. So in wrapping up, keys to success is it really does take an ecosystem. It takes all of us working outside of our roles and responsibilities and not stopping when we get to a roadblock, but looking at what do people need, how do we get there, who's paying for it, how do we build that case and the metrics, and how do we move differently as a community. It's leveraging that data, leveraging those ROIs and those innovative solutions. And what I would challenge all of us in this work is to identify the problem, own being the solution, and putting the care back in healthcare. And with that, I will stand for questions.
Thank you, Jennifer and Dr. Iton, for your presentations. Attendees, please continue to use the chat feature to submit your questions by addressing them to all panelists. And Ryan and I will alternate with those questions coming in to each panelist. And Jennifer, you don't mind, I'm going to start with a couple for you. One of the questions that came in was looking for innovative strategies between healthcare systems, government, and communities to address those health inequities. And I think that some of that you addressed after the question came in, but my question to piggyback on that is, you described things taking 5 years. How could we do it faster? I mean, you've kind of cut, you've cutting edge type stuff. How can we do it faster? 5 years? I don't know that a lot of our communities have 5 years to do some of the things you've done.
And that's a great clarification that I can provide. So the policy change took 5 years. What we did is, so in the withdrawal management as one of those examples, what we did is we immediately said, we can bring up more recovery beds. We need a funding stream for them. Health plans, if you're the ones that are going to gain money, what Medicaid allows people to do, it requires you to pay for Medicaid core services, but it allows you to pay for enhanced services as well. So it's a value-based model to say, we've got this service, we know it'll get better outcomes and lower cost, and health plan, are you voluntarily in? Are you willing to contract with us for this service? So we stood up an immediate response. What we then did is we didn't stop and say, great, Hennepin Healthcare has this great thing and Hennepin County residents can benefit from it, but we're going to leave the rest of the state behind. It was then going forward with the data we had and the success we had and working with the state and the federal government to get it. It had to go through our legislature. It had to go up through a waiver with CMS. That's what takes so long, but it is now available as a standard Medicaid set that everybody has access to. So the 5 years was really, how do you not have it be one system, but how do you really institutionalize? It's how we provide care.
And from the other end of the spectrum, the question we often get is, how did you as a leader move that culture really at the provider level that the social influencers are somebody else's problem?
It did take data, and it took figuring out what's the win for everybody. So initially we needed to identify who is involved in this market. I would use the jail example, going to the sheriff and saying, I think I can solve your booking problem, but I'm going to require you, if I'm successful, I'm going to require you to send your money from the sheriff's department over to human services, because that's who stood up the intervention. That was a long conversation. But at the end of the day, we said, your problem is you don't want to book the wrong people. If we show data that shows it, will you commit? And what they said is, if you can do it and it really does drop our volumes, we'll commit to moving the money. I had a longer term kind of fiscal plan mapped out that said, and then how do we pay for it longer term? So again, we're not reliant on one sheriff who was willing to share the money. But it was saying, who are the people who care, get the money in the table, build that business case, and then what did they win out of it? Withdrawal management example, the emergency department, it's hard to have chronic inebriates in your emergency department when you've got other traumas coming in. And it can be scary and it can drive others away from the emergency department. So we knew they were motivated, even though it was loss of business for them, they were motivated for a better outcome. And it was building, I had a different business case for each sector we were talking to, kept it simple, kept it at a one pager that said, here's what we can solve for you. Here's why you should care. Here's the metrics we're going to prove our case. And here's our commitment to long-term sustainability.
Okay, thank you. So I have a question for Dr. Iton. We have a lot of healthcare and corporate leaders listening to today's webinar, and a number of them have asked questions about how can they help. And in particular, they asked if you could provide examples of corporate policies that lead to health inequities, and what can corporations do to help remedy some of those problems.
Yeah, we talk about this all the time out in California. One of the things that we really do encourage. I mean, we have Kaiser out here, who's been a really good corporate partner. And one of the things that we recognize is that our system is very fragmented. And so you have a lot of incentives that run at cross purposes. And one of the challenges in the complexity of the healthcare system is to align those incentives and to recognize, as Jennifer's talking about, essentially where there are opportunities for win-wins. The greatest example I would give you, I mean, there are so many examples of corporate policies that contribute to inequity, but the simplest example, I mean, beyond predatory lending and a whole host of targeted advertising by alcohol companies, by tobacco companies, is hospitals that cite their institutions in places where they have higher levels of insurance rather than higher levels of need. That contributes dramatically to exacerbating need in communities that have need for healthcare services. You have similar behaviors on the part of grocery stores that cite themselves in places where they think they can get the highest level of return, but not where there's a great need for healthy food. So And I'm not blaming these corporations. They're operating in a system that incentivizes those precise behaviors. So the problem is not the people in those systems, it's the systems and how we structure the incentives to try to create health. The problem that we've struggled with is that the healthcare industry is kind of, in some ways, it should be a dying business. It's not, but it should be. Healthcare companies should be involved in creating health, not in selling medical care. And that's the problem that we have, is that there's huge incentives to sell medical services, particularly, the ones with high margins, and very little incentive to invest in the actual health of the community. That's the problem. It's not the people, it's the structure of the incentives.
Thank you. I'm going to pose a question, and I think that the attendees are interested in both of you answering. And that's one of the systems, if you will, or institutions not mentioned is our education system. We have questions from pediatricians and questions about how K through 12 education fits into the health services.
I can start by just saying that the data is pretty clear. The strongest and most significant modifiable social determinant of health is education. Income is probably stronger, but it's not as easily modified, and income is directly related to education. So if we were going to choose one thing, I would never encourage us to choose one thing, because these problems are complex and multifactorial. But, if somebody held a weapon to my head and said, choose one thing, it would be investing in a much higher quality K through 12 education to facilitate more people having access to 21st century opportunities. We've also created in this country very unattainable access to post-secondary education. The costs are excessive, they're complex. Another example of institutions that are creating disparities are, look at our Ivy League colleges. They do much more marketing and encouraging and ultimately admitting of the wealthiest 10% of our society than they do the bottom 90%. They are not levelers of opportunity. They are actually creating and maintaining an elite. And we stand by and we acknowledge that, we recognize that, and then we shrug our shoulders and we say, well, I don't know why there's a problem. The problem is that we've created systems that essentially skew resources towards people who are favored and away from people who are disfavored.
And I would just add to that, I absolutely agree. And you think about when you see the rates of failure of kids exiting out of school systems, there isn't an incentive to that point to keep that child engaged and to get creative in how we're supporting that individual or the family. The incentive is actually to say, once they're off the books, they're off the books, and it's not my problem, it's somebody else's problem. And what we need to own is that's our future workforce. Those are future people on public programs that we're supporting. And if we spend our money, to Dr. Iton's earlier graphic, smarter and upstream and investing in the success, healthcare needs to be accessible in those schools. It shouldn't be a school only thing to solve and competing against other education resources. Let's make it easy for kids. Let's talk about wellness and wellness around families and invest in those kids and those families' success early. And to Dr. Iton's point, creating career pathways. So no better way to spend the time than to have them getting into some of our corporate doors. So if you're a corporation, we've seen a lot of them starting to recruit earlier in college. Well, we should really be in the schools, and we should be giving kids experiences that demonstrate you belong here and we want you here. And we're going to create pathways for you to see yourself in our corporate environments as some easy steps.
All right, thank you. I think one last question about food insecurity as a social determinant of health. Can you talk about the problem and some possible solutions? I'll start with Dr. Iton.
Yeah, this is a big one. Food is probably the most important health issue. It has implications around nutrition, it has implications around jobs, it has implications around just hunger. It ties into land use and climate change. It's such a multifaceted public health issue that I think it deserves a lot of attention. The way that it's manifest most in our work is essentially people trying to find access to healthy, affordable food. And we know that there are food deserts throughout the United States. This is, again, the same kind of corporate behavior. Again, I'm not blaming individuals. I'm saying the incentives are to essentially pull healthy, full service grocery stores out of certain communities because of the financials, the way that they think that they can make money. And so what happens instead is you get fast food and you get, all kinds of poor quality food, and that is much more accessible for people in these communities. And then, of course, we have issues around quality of school lunches and et cetera. So I think that food insecurity is readily solvable by finding the political will to create the policies, as we've done in California, mind you. I mean, we've completely revamped school lunches. We've managed to essentially create a fresh food financing initiative in California, which has put grocery stores across low-income zip codes in California. The federal government had a similar one in the Obama years. There are solutions, and there are real solutions. Getting back to what Jennifer was talking about with respect to school suspensions and expulsions, we've cut them in half in California, and in some of our larger districts, we've zeroed them out completely. And we've seen test scores go up as suspensions go down. So there are very clear solutions to these problems. The issue is political will, and I would argue is sort of taking a market justice mindset as opposed to a social justice mindset, which leads to these sort of market failures, because the market is not in the business of feeding children, it's in the business of making profits.
And I would just add to that, knowing, I know you want to wrap up, is that so in healthcare, what can we do about that? A lot of healthcare systems, and we were one of them once upon a time, that cheered ourselves on because we gave a bag of healthy food. A bag of healthy food, a connection to a food shelf. Those are baby steps, but they don't solve the long-term problem. The long-term problem is usually undereducated, underemployed, access to benefits and services that longer time get you out of poverty. We take that long-term approach to say, we're going to invest in wellness, and we're going to make sure those programs are not only accessible, but we put employment and education programs within our walls in order to try to change that game. And so again, the short-term incremental versus keeping our eyes on the long-term, it's jobs.
All right, well, thank you very much. So in closing, I'd like to thank both of our speakers, Dr. Iton and Jennifer, for their wonderful, thought-provoking presentations and their time today. If we're in person, I'm sure you'd hear thunderous applause right now. Thank you very much. I'd like to thank my colleague Janet for helping facilitate our Q&A session, and the University of St. Thomas for providing us with this platform to bring the session to you. And we hope you enjoyed today's session. Please remember, in a few business days, you'll receive an email with links to a recording of the session, the slides, and the registration page for our next webinar, which is Friday, February 12th, which will start at 8:30 a.m. And again, it'll be Dr. Nathan Chumilo, the Medical Medicaid Director for the state of Minnesota and a Health Partners physician. If you are looking for additional professional development, please check out St. Thomas's Executive Education website. Lots of great opportunities. And again, thank you for joining us today at the University of St. Thomas. Be safe and be well. Thank you.